Hello, hello, and welcome to the Dr. Toomer Talk Show. I am Dr. Catherine Toomer, and we are going live in Facebook, YouTube, and LinkedIn. And if you're listening in YouTube and you haven't already subscribed, please subscribe to my YouTube channel. Actually, if you're listening from anywhere, subscribe to my YouTube channel. That's drtoomer.com. I'm sorry, youtube.com at Dr. Toomer. Wow. Okay. So, for those of you who are listening for the first time or even not, just let me know if you're listening and where you're listening from. Tell me your name. The other is, and if you listen later, put in hashtag replay and let me know where you're listening from there. Now, every month, usually I try to do this the first Tuesday of the month. Sometimes I don't, but I usually the first one of the first two Tuesdays of the month, I do a Q&A. And what this is that if you have any questions about health, wellness, and weight loss related issues, you can just ask me. If I don't know, I'll tell you I don't know. I'll go look it up though, and I'll come back and I'll do another video on it, or I'll give you the opportunity to ask me the questions after the video, and I will answer there. Anyone who has asked me questions at the end of my videos, after my videos, knows that I do answer all of my comments. So if you comment there, I will come and answer you. Now, the other is you can write to me at help@drtoomer.com. If you have questions you want to ask me anonymously, I actually, you know what? I forgot to check to see if I had any. Hold on just a moment. Let me just check real quick and see if anyone's written to me. Because I forgot. I told people to write to me and then I forgot to check. Okay, there's a couple. So I'll wait till if there's any questions from the viewer audience. Um, Ask me now. Now's a good time. So like I said, this is our October question and answer about all things health, wellness, and weight loss related. Hold on just a moment. I'm just trying to make sure I can see. Let me check a few things here. Forgot to put in the Okay, hold on. So if you have questions, you can put them right here. I'm just going to put in my email so that you know how to contact me later if you think of something later. And so there we go. That is my email address, and you can write to me there. So any questions from the audience? I'm trying to see if can you guys see me and hear me? Well, just kind of let me know if you can hear me and see me because usually at this point I can see more comments and I'm just wondering if, okay, so we got a little bit, hi from North Carolina. Anyone else? So if you can't hear me or if you just kind of see my mouth moving and nothing's coming out, just let me know. Just put it in the comments so I'll know. Um, Watching from Nairobi. Hello, Ochi, from Ochi's Farms. I grew up in Nairobi, so I'm not sure if you know that. But yes, I moved to Nairobi when I was a child with my family, and I came back for university to the United States. Even though my family is American, I grew up there, and I consider Kenya home, particularly Nairobi, and went to primary school and secondary school in my first year of university in Nairobi. So, Jambo. Um, Thank you for coming. So, anyone else? Oh, from Pakistan. Hello, Hassan. Welcome from Pakistan. So, we're having an international night tonight. This is wonderful. So, if you have any questions for me, please just post them in the chat. Normally, what I do for those of you who are listening for the first time, normally what I do is I have a topic and I talk about the topic. And and so that's usually week and usually the day before I post what that topic is going to be. If there's information that you want to know about, you can write to me at my email or you can put it after comments of one of the videos and give me a topic to speak on and I'll be more than happy to do that. And oh, nice. Hello, Dr. Toomer and everyone watching from Pennsylvania. Hello, Denise. Thank you for joining. Hassan, your dream country is the USA. I don't know about now, but I won't say anymore. Well, wonderful. I would actually have never been to anywhere in Asia, and I hope to go there soon. Pakistan and Bangladesh, India, any actually of the countries. Um, so, I don't see any questions in the comments now. Um, Hi, Nadine in Michigan. So that's my other home. Nairobi's one, and then Michigan's my other. So nice. Hi, Marcia from Barbados. Thank you for joining. You always come in. I always appreciate it. If you're not here, I wonder if I'm in the right place. All right. So again, for those of you who are just joining in, I'm Dr. Catherine Toomer. This is our October Q&A. If you have questions that you'd like to ask, I'm not sure if I can see them coming off of Facebook, so I'll look in Facebook now. My LinkedIn questions don't seem to come up, but I'll check there as well. And I'll just go into the app for those. But I can see the Facebook questions. So if you have Facebook questions, make sure that you ask me there. Let me just look in LinkedIn real quick here and see. Okay. And if not, I'll just go to the questions that I have in my email. So I'm going to pull those up. All right. So this question is from Rebecca. Won't say the last name. Okay. Oh, this is a question about two things, asking about consultations and also, hold on just a moment. Christopher donated. I don't know what that is. I think someone put something in the wrong place. Thank you for subscribing. All right. So, okay. Well, I have a question here, so I'll get to this one from Denise first, and then I'll do the next one. Oh, hello, Dave from On the Pen, Obesity Medicine. Now, listen, any of you who have not, if you're on a GLP-1, you are learning about GLP-1s, you want to know what's happening with GLP-1s on a political scale, on the social scale, on, just the nitty gritty, please go to On the Pen, and subscribe to that channel. The information is absolutely fabulous. It's actually where I get my information when I want to know the absolute truth of what's happening with treatment in obesity treatment and GLP-1 medications. That's where I go to get the information. There's so much noise online. It's really hard sometimes to kind of tell what's true and what isn't. But Dave Knapp On the Pen, you can't go wrong if you follow and subscribe to his channel. If you really want to know what's going on, that's the place to go. Now, I'll tell you about the health stuff and the medical stuff and the science behind it, but he's the one who's going to tell you about everything else. All right. So, Denise asked the question. I stopped Zepbound for 2 weeks for my colonoscopy. I was still eating the same and exercising 4 days a week, but my weight went up 6 pounds and I felt inflamed. Is this normal? Absolutely. So the reason that you felt this way, Zepbound, which is the same as Mounjaro, which is also tirzepatide, which is a GLP-1 class called GLP-1 medications. What these medications do is they absolutely treat what is glucose dysregulation. Now, glucose dysregulation is something that many of us have, whether you know it or not. And it may not ever show up in blood tests because a lot of the blood tests that we do only wait until it's farther into the disease state before it picks it up. But long before that, it's developing over time. During that development, when you have glucose dysregulation, there are a few things that happen. One, you have inflammation. Your body does not metabolize glucose properly. So what it does, the brain is not getting the glucose message, and it tells the body, make fat instead of fuel. So every time you eat something, whether it's a carbohydrate, but mostly carbohydrates especially, whether it's fat or whether it's a protein, when you eat it, your brain tells your body what to do with it. It gets broken down in your stomach, it goes into your intestines, the nutrients all get absorbed, and then the brain tells the rest of the body what to do with that. When the signaling is off during glucose dysregulation, the brain tells the body, it signals the body, take those calories that you've just gotten and put it and store it into fat cells. Turn it into fat and store it. So what happens when you're on a GLP-1 medication or glucagon-like peptide, which is the proper name for it? And then also with tirzepatide, which also has GIP, which stands for glucose insulinotropic polypeptide. I'm just saying all these things because I know there's some physicians listening, so I'm just giving them the absolute name, the scientific name. So What that does is it gets the signals where they're supposed to go. It gets all the nutrients into the cells, into the brain, and the brain says, okay, now I know what that you've eaten. I know you've eaten properly. I know what the signals are, and so I'm going to tell the body what to do. And what it does when the signals are getting through, it tells the body to make fuel and not fat. So even if you eat exactly the same way, you're exercising exactly in the same way, when you don't have the medication to get those signal substrates, the signals into the brain cells, so that the brain tells the body what to do, it missignals. And so it just tells the body make fat because it thinks you're starving. That is what glucose dysregulation does. Our brain uses glucose to determine what we're doing with food, what's happening with food, and it uses that signal then to send to the rest of the body. And if it's not getting in because of insulin resistance, prediabetes, diabetes, all on the same continuum, your body makes fat instead of fuel. This is the reason. This is actually obesity. We tend to focus a lot on BMI. And I'm just going to step on my soapbox just for a minute here. So we tend to talk about obesity as if it's a weight thing. We talk about obesity as if it's only about BMI. What obesity truly is our body's ability to make excess fat out of very few calories. It's from missignaling of the brain that tells the body make fat instead of fuel. And that is obesity. So whether you're overweight or not, whether you have a high BMI or not, you can still have obesity. Because what it is, it's a signaling issue. It's a metabolic issue. And what these medications do is they're metabolic correctors. So, talked a lot. I hope you got your answer, Denise. If that doesn't make sense, please keep asking. I'll just try to I will try to explain it a little bit better. Now, the other reason, and so the other thing that happens with the inflammation is that sugar in and of itself causes inflammation. So when it's not being metabolized properly, it tends to stay in the bloodstream, which means it goes to every single part of the body and it affects every part of the body. And that includes inflammation. So, that, hope that answers. The other is I hope your colonoscopy came out very well, because after all the things you got to do to get a good colonoscopy. And since you brought up colonoscopies, I'm going to say this also. It is really important, if you're on a GLP-1, it's important to stop your GLP-1 long enough before so that you get good bowel movements and you get good bowel cleansing. You don't want to have an incomplete bowel cleansing because it disrupts the test. It hides too much. And the whole point of a colonoscopy is visual, to see the whole lining of your colon to make sure there's nothing growing in there. So anytime your cleansing is not complete, it can hide and mask some things. And so it's not a very good test. One. The other, it's more important to have a really good, clean colon. And because you can always go back and lose that weight, but you can't, it's much more dangerous to miss something from a colonoscopy. So better to stop, gain a little weight if you have to, and make sure you get a really good test to protect you in the long run, because that weight can always just come back off. Lindsay says, I follow Dave, smart woman. All right. Let me see if I can find it. I may have missed some questions. Okay, so Denise, if that answers your question, just let me know. If not, I'll try to explain a little bit more. I talk a lot. Thank you. Yes, I was pre-diabetic. I have been back on Zepbound for a week, and the weight has come back off. Thank you. And that's it. It's the fact that these medications work is just proof that they're treating something. I always say, like, what happens if you take Tylenol for a headache that you don't have? Maybe I should use something else besides Tylenol, given the news right now. But but if you take Tylenol for a headache you don't have, what does it do? Nothing. And it's the same with GLP-1s. If you take a GLP-1 for weight loss and you don't have glucose dysregulation or metabolic dysregulation of some type, it doesn't work. The only part of a GLP-1 that may afford some weight loss is the mechanical part, which slows down gut motility. So it makes people feel full faster and longer. So it drops the amount of food you eat. But that is such a small component of what the medication does. It is such a small component of weight loss, and it stops eventually. So for weight loss to continue, for fat use loss to continue, there has to be an underlying metabolic process going on, dysregulation going on. It is treating something. Okay. Any other questions? Just going to, all right. So let me go to my emails. I feel like a game show or something. Going to my email. All right. Beverly asks, how frequently should you have a colonoscopy? It really depends on your family history and what was found during your prior colonoscopies. Asking your gastroenterologist or your colorectal surgeon, depending on who does your colonoscopy, or family medicine docs. I learned how to do them as a family medicine doc. However, I don't know very many family medicine docs who do them. But whoever does your colonoscopy will tell you how often you should have them. Generally, we're trying to get insurance companies to start covering colonoscopies at the age from 45 on. It used to be 50. If you have a family history, sometimes you need to start as soon as 40, especially if it's a parent or a sibling that had colon cancer. We're starting to see colon cancer in younger people. We think mainly it's because of the hormones that are in food or the hormone disruptors that are in packaging. And so we're starting to see it earlier. However, the general rule, if nothing is a problem, there's no family history, you don't have any polyps, and nothing was ever found, you start at 45 or 50 and you get them every 10 years. If there is anything found, it can drop anywhere from 3 to 5 years. If you have a strong family history, it can also be 3 to 5 years. If cancer is found, of course, then you have them every 6 months to a year. So, but that is definitely something that your whoever does your colonoscopy will tell you. But that's a very good question. And for every person it's different. So, and that brings me to another point. I'm going to step on my soapbox just for a minute again. So when getting medical information, you want to get it from the person who knows you the best medically. Not friends, not family, unless they're a physician who also knows your whole family, your whole history, then, obviously. But for the most part, the best place to get your information is from someone who knows you well. This is why it's very important not to doctor hop. Because the longer you stay with one person, the better they get to know you and the quicker they catch things. In medicine, particularly with the insurance having so much influence on how we practice, there are steps we have to take, and insurance often dictates what those steps are. When you go to one doctor and then before you go to the next step, you go to a new doctor, often what will happen, the new doctor will start right at the beginning again. Because one, they can't always trust the questions being asked by the prior doctor. And depending on how much time in between you've seen them, they may have to start all over. Insurance companies won't let them go to the next step until they've done the first step. And so the longer you stay with someone, the better physician they become to you. And the more information they have, the better they can get to the bottom of whatever the problem is. And therefore, unless someone is extremely disrespectful and rude, because you don't want a rude and disrespectful physician, then it's always good to stay with the person that you've got. And then let them get to know you and get to know you well. Hello, Ursuline. Thank you for joining. And Laura from Wisconsin. Nice to meet you. Again, so for those of you who are just coming on, and you may not know me, I'm Dr. Catherine Toomer, a family medicine community health physician and founder of Total Weight Care Institute. And what Total Weight Care Institute is a place where we give compassionate care to those who need it. We also connect patients to compassionate and caring physicians who are in their state so that they can get good care, as particularly weight management care, and particularly around GLP-1s, because there is an access issue and we want to make sure that people get the treatment they need and the treatment they want in a safe and affordable and accessible way. And so, and Jackson said, wow, I was really just thinking about switching doctors. Yeah. We all have our issues with doctors. Sometimes it's a personality clash, something. But this is the thing, and I know people talk a lot about bedside manner. Honestly, I'd rather have a brilliant doctor who's kind of rude and not very good, or kind of bland and dry, than someone who's really friendly and very nice, who's very loving, but doesn't know medicine very well. Because being nice is not going to keep me alive. Knowledge will. And so I always lean towards the knowledge. And that's where I focus. That's where I put my focus. The other is, I also know the limitations that we have in medicine to be really good doctors. Honestly, it's really hard to take insurance and be really, really good doctors in the amount of time that we're given to see patients. And so it often takes multiple visits to get to the bottom of what something is. The other is, if any of you have ever done puzzles or crossword puzzles, and you put a word in and it makes perfect sense, but then when you start digging deeper and you start adding other words, or you start looking at other pieces, you realize that piece doesn't really fit, or that word doesn't really fit, and you got to erase it and start and put in a different word. Medicine is very much like that. It's a puzzle. We're always problem solving. We're always putting puzzles together. We're taking symptoms from here, symptoms from there, things that have happened, history, and putting it all together to something that makes sense. So the better your information, the better you know the timeline of your symptoms and how to describe those symptoms, the better care you're going to get. Because that's what we use to determine what's happening. And before we get off, if there's some more questions, I'm going to answer them. But I will go back to how you can provide information to your doctor so that you get the best visit when you see your doctors. Michelle said, Dr. Millie Ma, check this out. I hope that's for a good reason. All right. Nitsa Gonzalez, watching from Florida. I also follow Dave on the pen, and Sabrina. Oh gosh, yes, Sabrina, I love her. I actually met her in person. She's as beautiful in person as she is online. Wonderful person. So Laura asked, do GLP-1 receptors become resistant to the body over time with Zepbound? No. So what happens is, not to get too technical, but the way things work in general is that we have what's called a bell curve. So we kind of treat and we treat and we treat and we treat and we treat, and then we get to a point where no matter how much more medicine you give, you're kind of not going to go any further. And kind of, you just kind of go. So all you're doing is just throwing more medication on something that's already happening. So there's a certain number of receptors our cells have. Our cells do change the amount of receptors we have, but I'm not going to get into that too much. However, when medication has hit all the receptors possible to treat the disease state that is possible, then it doesn't stop working. It just works. It's maximized its effectiveness. And so no matter how much more medication you throw at it and throw at your body, it's not going to work any better, because all the cells and all the receptors that can be used to treat have already been filled. Now, that doesn't mean you stop the medicine, because when you stop it, basically what your meat does is that it just reverses the benefit of the medication. So what that means, though, is that you've reached the max of that medication's effectiveness. Medication, GLP-1s, are just one tool in the toolbox. There are some people who may lose weight to the point where they have GLP-1, where they just can only need a GLP-1. And that's fine, except that doesn't help prevent falls later from weakness because of muscle loss. So you still have to eat protein so that you still have to build muscle and maintain muscle. You'll still have to address the stresses of life and cortisol so that it doesn't keep Your body isn't dependent as much on medication, and it can use other things that do some of the heavy lifting. Getting enough sleep, drinking enough water. There are all these other pillars of weight management. There's all these other pillars of metabolic management, and medication only touches one. But because it's such an effective tool, often what happens is people don't do anything else. And that's fine on the short term, but over time that can become a problem. Mainly because the muscle we make now determines our independence later. The muscle we make now determines how safe we are later moving about, how well we can take care of ourselves, how well we can get up out of bed, out of chairs, how well we can stand and brush our teeth, how well we can bathe ourselves, how well we can wipe ourselves when going to the bathroom. Muscle now is what determines whether that happens later. So if you don't work on muscle now, you have to depend on somebody else's muscles later to do it for you. And so medication may get you to the point where your metabolic status is fixed, but it will not protect you from other psychosocial things later in life. It does protect your heart from heart disease. It does protect your kidney from kidney disease. It does protect your brain from dementia. It protects almost everywhere against inflammation, but it will not protect you from falls. It will not protect you from your activities of daily living later in life. That you've got to work on now, and you've got to work, and wherever you are right now, you work on that and it's going to help. Okay, that was a really good question, by the way. So no, they do not become resistant. Marcia, and it sounds like you're truly a good doctor. You're always so thorough. Thanks for caring. I appreciate it. I appreciate that, Marcia. To be honest, I became the doctor I needed when I needed a doctor the most. I've always wanted to be a primary care doctor. I've always wanted to be someone who helped people figure things out. And that started because it was a doctor who caught my father's colon cancer very early. And when I asked him, when I was little, I was about 8 years old, and I heard he had cancer. And cancer to an 8-year-old means death. So when he didn't die, I thought, well, wow, how did that happen? And he explained to me that it was because the doctors he had caught his cancer early, and therefore he survived. And I remember at that moment saying, I am going to be a doctor. And I never wavered since. And so I've always in my mind felt it's a doctor's job to find things and keep people alive. That was my first introduction to what doctors are supposed to do. And so that's what I became. Unfortunately for myself, when I was 100 pounds heavier, and I had really bad diabetes, uncontrolled. I was had class 3 obesity. I went into congestive heart failure and was misdiagnosed because of my obesity. I was told that the reason I was tired, the reason why I couldn't move around without getting short of breath, the reason that, I was having heart palpitations was simply because I was overweight, and if I lost weight, I would be fine. Well, 2 weeks after that, I was hospitalized with my heart failing to the point where we thought I was put on a heart transplant list. One of the reasons why I am such a big proponent and a big advocate for GLP-1 medications is because I was put on a GLP-1 medication 14 years ago. Yeah, we've had them since 2005. They're not new. And I was put on one 14 years ago to help my heart, to protect my heart against my congestive heart failure. I happened to lose weight in the process, and my diabetes got controlled in the process, but I was put on it to protect my heart. They are very, very cardioprotective. And so because of that misdiagnosis, because of the way I was treated, because I had colleagues saying, how did you get like this? I decided to make sure I never, ever became that kind of doctor. In fact, became the opposite. And if there is such a thing as caring too much, which I don't believe there is, then that's me. So and the way we protect ourselves is with information. And so I share the information that I have. I am not a gatekeeper by any stretch of the imagination. I'll tell anybody what I know. But thank you so much for that, Marcia. And actually, tell me now. I've been calling you Marcia, but I know Marcia is also the way of pronouncing your name. So if I'm mispronouncing your name, please let me know. Nadine says, I'm taking a GLP-1 and I also take a multivitamin and a probiotic, vitamin D and omega-3. Are there any vitamins that conflict with GLP-1s that I should be aware of? None that conflict. Now, there aren't any, but with any of the supplements that are taken, you want to know whether they're water soluble or fat soluble. Now, the reason that makes a difference, and I'll tell you which are which. There's only 4 fat soluble ones: vitamin A, vitamin D, vitamin E, and vitamin K. The reason that you need to understand if they're fat soluble is because those are the only 4 vitamins that you can take at toxic levels, because they can get stored in our fat cells and our body can absorb it all the way. And so if you take too much of something, you can have problems. Vitamin D and vitamin K our body uses to absorb calcium. Calcium's good when it's for your bones. Calcium's good when it's for your muscles, including your heart muscles. Calcium's good for all the different reactions in our cells that calcium is used, which is a lot. The problem with that, if you have too much calcium, then you start getting kidney stones. And that's a problem. So you always want to make sure that your vitamin D levels are not too high. And usually we can test those. Most people don't have vitamin D levels that are too high unless you're taking supplements. Now, when it comes to the water-soluble supplements, your body just takes what it needs and then pees the rest out. So it's rarely toxic. But the other, though, is CoQ10 is one I don't see in there. That's very, very good for your heart. The other is, if you take calcium tablets, calcium supplements, you don't want to take calcium supplements around the same time that you take your other medication. Calcium has a way of binding to medications and so making them less effective. So you just want to take your calcium away, at least, 3 to 4 hours away from your other medication so that it gets dissolved and absorbed if you need it. Which we do. The younger, if you're under 40, they say 35. I go to 40 because it's like this. It's arbitrary, but you do need calcium to help build your bones, and the earlier you start supplementing, the better. If you're not someone who drinks milk or eats cheese, if you have lactose intolerance like I do, you tend to have to supplement your calcium, and the earlier you start, the better. The other thing, though, that makes your bones strong apart from calcium is using the muscles on either side of them, or using the muscles that attach to your bones. So that's why muscle work is also very important. So we in the Caribbean say it as Marcy. Pronunciation is Marcia. Okay. I still like Marcy. That's still pretty. So, but I like to say people's names the way they say their names. So Marcy. All right. Any other questions? So let's see here. I do have one question. We're getting past the 30-minute mark. I try not to keep you guys for too long. So I'm just going to ask this one question. Let me see. Oh, well, I got one question about how can someone work with me? Well, this is just a quick question. Someone sent me an email asking how they can work with me. So essentially, if you go to my website at drtumor.com, there are a couple ways that you can. One is a strategy and plan appointment. And what I do in strategy and plan appointments, I look at all your medical history, I do an assessment and determine what's going on with you, and then give you an idea of how to get healthy, particularly around weight management. if a GLP-1's right for you, if it isn't, and if it is, and it's something that you think is important, then we figure out a way of getting you that medication either through your insurance, brand, or compounded. I am also very much a proponent of compounded medications simply because, one, it helps people get it at a more affordable way. Two, I vetted the company and found out actually that the medication that I use comes from the exact same facility that some of the brand is made in, one, and two, it was one of the facilities that the FDA monitored during the shortage. And so I made sure of that. And so I do use them when I can't get it any other way. And when I say if a GLP-1 is appropriate for you, now a lot of times they say on the thing, whether it's because you have an A1C over a certain number, you're diabetic, or if you are, your BMI is over a certain number. My only criteria for prescribing a GLP-1 is if there is a metabolic issue going on. I do not care about BMI. In fact, I don't even, I only use BMI to get things covered by insurance, if insurance does cover things based on BMI. But for my criteria, it's only if there has been some demonstrated weight gain because of a metabolic reason, regardless of BMI. And the reason that is, for example, a woman who's in menopause, whose estrogen drops, whose cortisol now is dominant, who now is in insulin resistance, can easily gain 10%, 15% of her body weight and still not have a BMI that corrects, that is within the criteria for GLP-1. However, a GLP-1 is the perfect medication to correct that metabolic issue. The key is monitoring very, very well so that there isn't too much weight loss in the process. And that's it. And so, Wanda, I'll put my email in just a moment before I forget this thought, because if I do it now, I will forget. So the thing is, when it comes to GLP-1 medication, the most important thing is that it needs to be treating something. And the way we know it needs to be treating something is through a good history. There are few things that cause metabolic disruption regardless of BMI. Menopause, polycystic ovary syndrome, chronic stress. So that's why men and women, this isn't a woman issue. This is a person issue. Low testosterone, whether in men or women. Pre-diabetes, we already know. Diabetes, we already know. But insulin resistance for whatever reason. And so taking steroids, for example, long-term steroids will do the same. Sometimes hypothyroidism will disrupt it, but it also makes it a little bit more difficult to treat just because the hormone push and pull sometimes gets in the way, but that's also something that, we can work around if necessary. So Wanda said, what's my email address? I'm going to put in here. It's help@drtumor.com. So I already answered the other question that I read, which is about testosterone and whether it's helpful. Now, testosterone in men is helpful and protective because it's kind of like for any woman who's gone through menopause or perimenopausal who just kind of feels like they don't feel like themselves, which for me is a real symptom. Not feeling like yourself is a real symptom. And just as an aside, when you have perimenopause and even going into menopause, your hormones can stay normal for years. Perimenopause is a clinical diagnosis, which means is diagnosed based on your symptoms, not your labs. So just know this. So when you go to your doctor and you say, I'm feeling this, I think I might be going into menopause, and they check your labs and tell you, no, you're not, that means that's a clear sign they're not listening to you, because it's listening is the only way you can diagnose perimenopause, is by listening. The other is, so one of the things that happens with perimenopause and menopause is that estrogen and progesterone drop. And normally what happens is that it protects cortisol. This is cortisol pushing with this way. This is estrogen and progesterone pushing this way, and it keeps it in check. But then when the progesterone and estrogen starts to drop, there's nothing protecting you from your cortisol. And that's why insulin resistance happens. That's why weight gain around the middle happens. That's why irritability from blood sugars happen. That's why hot flashes happen. So a lot of the symptoms that we have of perimenopause and menopause are from glucose dysregulation. And that's why low dose GLP-1 medications helps to counter that. And like I've said before, and I'll say it again, you can mark my words, GLP-1, low dose GLP-1 medication will become standard of care for menopause and perimenopause if anyone pays attention to women and what we really need. Now, when it comes to testosterone in women, we actually make more testosterone than estrogen. We just don't make as much as men do. There's no point in testing women for testosterone. It's going to be low based on the scales of labs, because the lab scales are based on what men make. So we're always going to test low. But as ours drop, we start having issues with libido, just like men. Men notice it as erectile dysfunction. Women start to notice it as disinterest in sex, lack of arousal, lack of interest. And so replacing testosterone saves marriages. And I'll just say bluntly, it saves relationships, not just of any kind. It just saves them. Progesterone and estrogen replacement keeps sex from becoming painful for women. It also prevents urinary tract infections, which prevents urosepsis, which is basically bacteria getting into our bloodstream. So it's really important to replace hormones, either vaginally, so that the uterine vaginal lining stays nice and thick and moist and doesn't cause any issues with pain or with infection, or systemically, so that it keeps our cortisol in check and stops weight gain. Now, it will not reverse the weight gain. Only a GLP-1 can do that, but it will stop it from getting worse. Now, with men whose testosterone drops, they start noticing erectile dysfunction. Again, this is my rule. You treat the person, not their labs. If a man says he's having difficulty having an erection, or he has difficulty sustaining an erection, or he's losing interest in having sex, and it's not because he doesn't like his partner, because that can happen too. Same with us. If you don't like the person, you're not going to want to be with that person. But if everything lines up, so it's only about something physical reaction and not some psychological reaction, then no matter what the testosterone shows, there is a testosterone issue. Period. So, I've been stepping on a lot of soapbox today. Mainly because I get so frustrated when I see people being half-treated, undertreated, or dismissed, or ignored. And that happens far too often. And mainly because a lot of it has to do, unfortunately, with how we have to practice medicine now. This is the reason why I do not take insurance, because I like to spend an hour with my patients. I cannot do that if I take insurance. I wouldn't get paid for any of it. So, any other questions before we sign off? This was a little bit of a longer one. A lot of good questions, a lot of interaction. Thank you all for coming. Don't forget to subscribe to my channel. And I'm trying to get to 5,000 by the end of the year, so help me out with that. Marcy says, have a good week ahead, everyone, and thanks again, Dr. Toomer. Well, thank you all for coming, and I really appreciate you being here. Again, just write to me at help@drtoomer.com, or right after, or you can put comments after the videos, ask me questions after the videos. I do get notified, and I do go in and I answer them. Oh, Jennifer has a question. What vitamin can we take to make ourselves feel better in menopause? Now, vitamin H, which is hormones. That's it. You can take others like, vitamin D, obviously you need that. Vitamin C to help against, help with immunity. Vitamin D, vitamin C. I'm making sure your iron and your ferritin levels are normal. Now, ferritin is what our body actually is an indication of how much iron we need, not our iron levels. So getting a ferritin checked, making sure your liver and your kidneys are working properly, making sure you're hydrated. Dehydration is probably the number one cause of fatigue that we overlook. The other is, so when I say vitamin H, I mean vitamin estrogen, vitamin progesterone. Progesterone will help with sleep and a lot of other secondary symptoms. Estrogen will help keep your body in balance. And if you cannot take systemic estrogen for whatever reason, if you have a family, like a strong family history of breast cancer or a history of your own breast cancer, even though estrogen does not raise your risk of breast cancer, it only makes estrogen sensitive breast cancer worse. So that's why we say if you've had breast cancer, especially an estrogen sensitive breast cancer, you can't take it, but you can still take it vaginally. You can still protect yourself from painful sex. You can still protect yourself from urinary tract infections. Vaginal estrogen does not end up in your bloodstream. So you can still protect yourself that way. And it'll make you feel better. So the other vitamin H, which is hormone, is testosterone. We make more testosterone than estrogen. So when we replace it, we feel more like ourselves. I hope that answers your question. Multivitamin really is just any really good multivitamin is good, is appropriate and is enough usually if you don't have any deficiencies. The only vitamins that have been truly tested that I know of is Nature's Bounty and Nature's Made. You can get them at any CVS, any pharmacy or grocery store. You don't have to go with the fancy ones. You don't have to go with the expensive ones. Supplements are one of those things where the more you pay for them does not mean they're better. It just means you're paying more for them. And like I said before, if they are water soluble vitamins, you can take extra if you want. 100,000%, 2,000% of what your body needs. Basically, what that does is gives you very expensive urine because your body just pees it out. Is it true that sugar can make hot flashes worse? Absolutely. Sugar and alcohol. And mainly what it does is because your hot flashes are come from parts of your brain. You have thermal regulators in your brain, and your brain the cells uses glucose to determine what it's supposed to do. When you bombard your brain with sugar because it's either too high, can't get in, or something else, it just goes haywire. And also, sugar in and of itself is a very quick source of energy. When our body makes energy with glucose or anything we eat, it heats us up. And so yes, you get heated up, you get hot flashes, you get all sorts of things with sugar. Sugar makes everything worse, to be honest. Our body just does not function well when we eat sugar. And you can eat sugar, but you should eat it in moderation, and you should always counter it with a protein and healthy fat. You should never eat sugar by itself. So that means drinking sodas, sweet teas, fruit juices, soft drinks. All of those things are sugar that goes directly into the body and causes problems. What is the finger red number one? What is, I'm assuming you put an emoji up there because it's just describing it rather than showing it to me. A supplement people should take. You should just take a multivitamin. That's the one. You should just start at a multivitamin and then talk to your physician about anything else that you might need. People who have heart conditions, usually we're told to take selenium. We're also told to take CoQ10. If you have, brittle bones and other, or you have, a family history of osteoporosis, we're told to make sure you take vitamins, calcium, vitamin D, and vitamin K. If you have a history of heart disease or dementia in your family, omega-3 fatty acids. So it really just depends on your family history, what you're trying to avoid, and then what your diagnoses are. And the best person to ask that is your physician. You can do some research, but this is what I recommend. When you do research, go to the National Institute of Health. Do not go just straight up to the internet and ask anybody. Everybody's going to have an opinion. And most of those opinions are false, or they're anecdotal and they have nothing to do with you. So the best thing to do is to go look at research papers, like actual work that has been done, actual research that has been done around the issue, and that would be the National Institute of Health. All right. Well, it is, wow, almost an hour. I'm going to say good night and thank you all for coming. Thank you for your wonderful questions. I will be here again next Tuesday. Actually, let me just say something. I won't be here next Tuesday. I'm going to be traveling. I'll be out of the country and I won't be able to coordinate the time. So I'll put something out there to let you know that I won't be here next Tuesday, but I will come back the following Tuesday live for you at the Dr. Toomer Talk Show. All right. Good night.